Welcome, everyone, this evening. It is my absolute pleasure to introduce our subject matter experts. Tammy Kress is the Vice President of Clinical Solutions and Innovation for Teladoc Health. Prior to joining Teladoc Health, Tammy worked as a telehealth consultant, advising clients based on her experience at Providence St. Joseph Health, where she built the telehealth division from the ground up. Tammy has demonstrated a record of leading strategy, operations, and transformative initiatives with deep telehealth subject matter expertise across inpatient care solutions. Tammy is a military veteran with a proven track record as an energetic change agent in multiple complex business lines across highly regulated multi-state services. Welcome, Tammy. We have Kelsey Cox, who is a Director of Patient Care Services at St. Luke's Health System located in Kansas City, Missouri. Kelsey graduated from the University of Central Missouri in 2011 with her BSN and completed her MSN in 2017 from the University of Missouri. After becoming director in 2020, Kelsey oversaw the opening of a new 33-bed unit that was the first in the system to trial a new care innovation incorporating virtual nurses into the care team. In 2022, she assumed leadership responsibilities for the newly developed Virtual Expert Care program and led the program system expansion, growing services from a single 33-bed unit to over 550 beds with the St. Luke's Health System. Welcome, Kelsey. And finally, Dr. Carol Rosenberg is the founder and CEO of ReadySimGo, a startup company dedicated to improving patient and family caregiver discharge education through hands-on simulation. She has been a pediatric nurse for over 20 years and worked for the first simulation company to address the learning needs of nurses. Dr. Rosenberg is a national nursing leader in pediatric quality improvement, patient safety, and patient family-centered simulation, and is an adjunct faculty professor at the Johns Hopkins School of Nursing. At this time, we'll have Tammy begin her presentation.
Thank you for the introduction, Olivia, and good evening, everyone. I'm so excited that I've been asked to participate tonight in this innovation session, and just excited to have the opportunity to share my story and also to have the chance to engage with you directly in chat and in the Q&A. So my approach for the next 15 or so minutes is going to be, I will share with you how I got started in innovation, my thinking along the way about moving from bedside nursing to a nurse leading innovation, and my current situation of being an innovative leader at Teladoc Health. Next slide, please. So I've been a nurse since 1996, and I worked for about 5 years in bedside and charge nurse roles across multiple types of nursing units before taking on my first innovator role. So 5 years into my career, I was approached by a physician executive leader who has honestly been my lifelong mentor, and he's pictured with me in the bottom right of this photo. And he was looking to establish a stroke program at a 4-campus metropolitan acute care hospital in Seattle. And he was the stroke medical director, and he was looking for a stroke coordinator who would be responsible for developing and managing his stroke program that he was getting ready to develop. And I recall the day like it was yesterday. He approached me, and I didn't even know who he was. And he asked me if I wanted to be a change agent. I was surprised first at his ask, but then I eagerly explored his idea because I wanted to understand his vision and what he was hoping to solve for. And goodness, why was he talking to me? I didn't know him. So I remember going home that night and wanting to think about this opportunity. And I was introspective, curious if I had the skills to be successful, curious if I would be satisfied in a new role, because I loved doing bedside nursing. And I knew that if I took this role, it would be my first step away from providing direct patient care to instead developing programs and systems of care to deliver better care to entire patient populations. I had a lot to think about, to say the least. But after a good night's sleep and talking with my family, I made the leap, and I have never looked back. Little did I know, 3 years later, we would be awarded the top disease management program in the United States by the Joint Commission for our use of quality data to measure and improve performance. And that's the celebration picture that you see to the left of this slide. I learned so much over those 3 years, and it was an awful lot of fun to get to celebrate it. And specifically, I remember when we received that award, really recognizing that this was the beginning of really launching my career, and that I have figured out, at least the first time, how to develop systems. So following the success of our stroke program, we hosted a statewide educational series about stroke care in Washington state. We were in the stroke belt at the time. And we took a really hard question from somebody in the audience, and it wasn't a medical person, it was a lay person. And their question was, we live in a very rural state, and you're talking about all of this fantastic care and more specifically outcomes that you're delivering at these downtown big hospitals in Seattle for stroke. What about me? What about my family? We live out on the Olympic Peninsula. It's going to take us 3 hours to get to you. How do we get the same level of care? And quite honestly, we didn't have an answer that night. And we said, we'd get back to you. But what I loved about this is that this ended up being the next step on my innovation journey. And it propelled our organization with that very provocative question to figure out how to develop a telehealth program. So next up, I was asked to lead the development of the first telestroke network in the Pacific Northwest. This was back in, I think, 2005, before telehealth was really a thing, and it was certainly not the standard of care yet. So I went through a lot of the same introspection. Do I have the right skills to develop a telestroke network? But I didn't hesitate as much that time around. I started to get excited about it and starting to put into place the plan, and I definitely accepted the challenge. But the big thing that I learned along this particular journey of developing our first telestroke system in the Northwest was the power of team. We had done the power of team to develop our stroke program. And as we started developing systems of telestroke care in Washington state, that's the upper right-hand photo, that was us celebrating that in less than 2 years from this question in the audience. In less than 2 years, we had developed all of the infrastructure and programs to deliver telestroke, and we were live in 18 hospitals across Washington state, vastly improving access to care and vastly improving patient outcomes. So it was very rewarding to go through that. So I realized I was onto something, and that I was quite energized, just like I am tonight, about the work. And I wanted to do my next innovation. And I did it a little bit differently this next time. Instead of waiting for somebody to come to me and ask if I was interested in a new role, I took the initiative and I developed my very first business plan to evolve the telestroke program into a telehealth division. And I had to learn a lot to do that, because we don't really learn how to develop business plans or write business plans in nursing school. I think we all know that. I had to figure out how to do that, how to present to executives, how to get approval for lines of business. And I did get that approved. And we launched successfully. We developed multiple use cases and telehealth capabilities before I moved to a parent health company within my system and took over centralization of telehealth across 8 states. So if I slow down and I reflect on that journey that I just told you about, how I got into innovation, I don't know exactly when it happened, but along the way, I figured a couple things out. That I have a deep passion, a calling for bringing the highest quality of care to patients and enabling staff to do their best work, systems of care. And so I decided to make one more move. And I think this was my last move in my career that I intend to make. And that was me deciding to leave working within hospitals and health systems and transitioning to the work that I lead now at Teladoc Health to shape how telehealth is delivered to health systems around the world. So a much bigger role. Next slide, please. So you might wonder why I chose to work at Teladoc Health. And So much of my journey for Telestroke and the other telehealth stories that I just told, they were enabled by Teladoc Health. And I saw, and I was inspired by innovative mindset, solving the hardest problems and use cases in telehealth at the time, Telestroke, time, second, brain count, right? And thirdly, I was inspired by the leadership. And so this is just another pearl that I'll mention to you is you're always looking at what is next in your career. But I recognized pretty early in, and I mentioned my lifelong mentor, the stroke neurologist who recruited me for my first innovative job, but that your leadership and the people that you surround yourself with will either enable you or they might not support your creativity. And clearly, the early work that I saw at Teladoc when I was a client of theirs is really what brought me to Teladoc Health 3 years ago. Next slide. So I arrived at Teladoc at the beginning of the COVID pandemic. And as we all know, the pandemic created new challenges and it put enormous pressures on the nursing profession. Next slide, please. Specifically, the enormous pressure that I want to talk about with you tonight is workforce challenges. These were obviously a challenge before the pandemic, but they were amplified during the pandemic. And these staffing constraints are going to continue into the future. We all have heard the statistic that there is a deficit of 2.1 million nurses to provide care in the United States by 2025. And that is, a year and a half from now. And when I have the opportunity, and I do this daily, to talk to hospitals and health systems, every single one of them is on a journey to evaluate their workforce strategy, making sure that they have what they believe is the right path to optimization, that innovation is a required investment area because the numbers don't add up. We know we just can't keep doing things the way that we've always done them in healthcare. Next slide. And I feel blessed that since I joined Teladoc, I truly was empowered by the leadership to rethink our strategy, to reinvent who we are. And in my role, I lead multidisciplinary team members to develop new and innovative, or to evolve our current solutions to solve for the biggest problems, workforce in this case, and downward financial pressures. I really believe we're changing the world with our solution and approach. And what we're doing is we're enabling hybrid care, which is bedside care, redefined care roles with virtual staff, redefined care roles, and together doing better, more effective, more efficient, highly satisfying care for sustainability. So it's improving and giving them options for how their teams can reinvent themselves and do work together. So it's about technology, workflows, and people. Next slide. And the results are very promising about this work. And these are examples of what our partners are reporting to us who are using our solution and our approach, reporting as their outcomes from they are retaining their nurses, they're more successfully recruiting nurses. And that is both bedside nurses and virtual nurses, that their patients are loving it, that physicians are selectively admitting patients to these units because they're seeing better care, higher touch, better satisfaction. So it's all very directionally correct. And it is, for me, incredibly inspirational that we are chasing and we're doing the right things. Next slide, please. And to go just a little bit deeper on some of this data as examples, this is an example of a partner who, in their first year of implementing a hybrid virtual and bedside nurse approach, saw a 73% improvement in retaining their nurses and a 55% improvement in retaining the other staff working on that virtual nursing unit, because they saw how the teams were working differently together, how they were enabled to transform care, and how they were part of the future. So these results are driving reality, and they're driving the adoption of virtual nursing as part of hybrid care delivery very excitedly. Next slide. So another thing that I'd love to share, and that it always excites me to get to say this, is that I have watched the nursing profession for many years. And what I'm seeing right now is a big difference in the strength and the voice of nursing leadership. Like never before, I'm seeing that nursing is increasingly leading the charge at their organization on the selection and implementation of solutions that not only help them to solve for nursing challenges, you think of silos, right? But rather, I'm seeing nursing lead the charge for horizontal thinking and how do solutions and partners enable the entire care team to think about how they deliver care as we head into the future. And what excites me about that again is the nursing voice and the nursing power, because nursing gets operations probably better than anybody else in a hospital, health system, or in a clinic. Next slide. And one more example is just what virtual does to our profession when you think about innovating and changing. We had a partner who shared with us that they posted they posted 4 virtual nursing positions, and within a few days had over 100 qualified applicants. And so they had to take the position down because they were very satisfied and they wanted to move forward quickly with virtual nursing roles filled. And nurses are seeing that virtual is just a great career ladder for them, for the profession, as a way for them to continue to practice, but in a different way, as part of a different care team model. And so I will finish with the following comments if you'd like to go to the last slide, Olivia. I know we're up against time, and I'm very eager to hear from the other experts joining me this evening. But some of the takeaways that I'd like you to reflect on. The first is, don't innovate for the sake of innovating. Innovate to solve a real problem. Examples for me were innovating to solve for the quality of stroke care delivered in my organization, to access to the best telestroke or stroke care in the state, to redesigning systems of care so that entire care teams can more sustainably and with more satisfaction deliver the highest quality care. Number 2, what's in your DNA to make you an innovator? For me, I did a little bit of consulting, but what I really chose for me is I like navigating large corporations and large health systems and bringing the power of team together to deliver greatness. And so in my DNA, it's large corporations. For you, it may be building a company or spending off your own business and becoming your own consultant. They both are so valuable. Number 3, and I just said it, leverage the power of team. Find people with a shared vision, surround yourself with them, and obviously that will help you to go so much faster. Innovate with the big I and a little I. What do I mean by that? When I think about the journey that I'm on with you as my nursing colleagues, we are innovating. How do you deliver care at scale to patients? That's the big I. The little I are all of the things that we do along the way to achieve that big I. It could be, how do we actually deal with virtual nursing admissions, or how do we deal with virtual nursing staffing? And you have to knock each of those barriers down and come up with ideas and solutions together. And each of those helps you to achieve that big goal that you set out to achieve. And lastly, you can join an organization such as the ANA or another special interest group as a great way to get involved. And as you can see, work with your other colleagues interested or doing identical work. So in close, I think that healthcare is experiencing challenges like never before. And my mindset about this is how we together can innovate and change so that these challenges turn actually into opportunities, like a career ladder. And clearly, the need to innovate and reinvent ourselves and our profession is pressing. So I hope that my story sparked interest or curiosity for you about how you too can be part of the transformation that we need in nursing, and how innovation, in my opinion, is playing a very important role. So with that, I'm super excited again to be here tonight, and I look forward to learning from my colleagues.
Tammy, thank you so much for an excellent presentation. Just like Oriana has said in the chat, for anyone in the audience that has questions for any of the presenters, please put them in the chat and we'll get to them at the very end, and they'll be marked with a question mark. So thank you so much for your questions in advance. But Tammy, just a question before we move to the next presenter. How do you feel that virtual care promotes patient-centric care?
That's an excellent question. I think it depends on the model that you are implementing and the processes that you implement. But what I see generally for how it promotes patient-centric care is this. If the model includes things such as giving them choice about in-person or virtual, it definitely improves access to care. It improves things like more touches, people checking in, being able to provide whether it's support or information or physical or non-physical care that makes them healthier. All of these things come together to improve not only their care, but also, as I mentioned, improved patient satisfaction. Patients are loving virtual care increasingly, and I feel confident that it is going to be our future.
Wonderful. Thank you so much.
Sure.
At this time, I'd like to hand it over to Kelsey.
Hi there. Everybody hear me okay?
We sure can.
Perfect, thank you. My name is Kelsey Cox. I'm a director of patient care services at St. Luke's Health System, which is an organization in Kansas City, Missouri. Susie Krug is the chief nurse executive for our health system. She had to go to another event this evening, but I've been working with her on this project really since the inception, since we started our very first pilot unit. So I'm excited to get to tell you all about what we've been doing at St. Luke's, how we have not only implemented virtual care, we call our unit virtual expert care because we include modalities outside of strictly registered nurses. We'll talk a little bit about nurses today, but also some of the other modalities that we have live utilizing the software, and just a great experience, not only for our patients, but also our internal customers, our nurses, our nursing assistants, and really anyone who comes into contact with our solutions, and how it's really trying to improve the patient care, improve our patient satisfaction, and just overall decrease the burden of some of what we would consider to be more physical tasks or more non-physical tasks, those administrative tasks that we see occurring within the hospital that a lot of times we need a specific staff member to do. So you can advance to the next slide. This slide you actually kind of already heard a lot of information about from our previous presenter. And when we are looking at why would we change the care model that we had at St. Luke's at the time, not only were we looking at what was happening in the hospital directly at the time that we were making and implementing our changes, but also looking future state at what our pipeline was going to be for the staff that were going to be able to help take care of our patients. And we saw that not only was there going to be a 73% increase in our population over age 65, but that those patients that are living longer have more comorbidities, and just the implications of living longer with those chronic conditions. So we know that the demand for healthcare services is only going to increase. It's definitely not going to decrease, and that we are going to need to have solutions in order to figure out how we could address those needs and do so in the way that St. Luke's has been really proud of doing for lots and lots of years. You can see the statistic we have related to 2030. So 1.2 million new RNs will be needed by 2030 to address our current shortage, not any shortages between now and that time. I think that this slide is so important because I continue to hear even from current staff nurses who are new to the profession, and then some of our more experienced nurses, they don't really understand or grasp that we have this deficit that is only continuing to grow wider and wider, and that Like was previously stated, we cannot continue to do what we've been doing the way that we've been doing it, given the staffing crisis that not only a lot of us experienced the last several years, but what that staffing crisis is possibly going to look like in the next several years. So one of the things that St. Luke's wanted to do and knew that we had opportunity in was to leverage technology that we had in place to extend our clinical expertise and reduce that workload at the bedside. I know workload is being talked about a lot through different organizations, the workload of each individual, how some of those things can be decreased, how some of those things can maybe be managed differently. And we knew that with some of our technology solutions we had in place, we were going to be able to change what that looked like. So you can go ahead to the next slide. So again, we call this virtual expert care, and that's because we have multiple different groups that work through our virtual platform. Today, we're talking a little bit more related to the nursing side. Our nurses and our VEC focus on the admission database, initiating vaccine standing orders. If a patient has an MRI ordered or is needing an MRI screening form completed, our virtual nursing team can take care of that. Also, we complete portions of the patient plan that is not actually contained within our admission navigator and our EMR. And then we can also help with our 2RN skin check. As far as discharge, we'll complete the discharge navigator, which includes patient education, medications on discharge, and then any additional follow-ups that the patient needs. In addition to that, not listed here, we can help complete dual medication checks, whether that is a heparin drip, hanging a new bag of blood. We have the ability through our software to be able to zoom in and see what that medication is and do that independent double check with an experienced nurse. That's a big satisfier for staff to have the ability to have someone come into the room, because I know I have personally walked around a nursing unit looking for someone to sign off on blood with me and spend more time walking around than it probably would have taken to complete the workflow. So to be able to reach out to someone from a technology standpoint that is available at an offsite location to do that with me and to not have to have that time spent looking for someone has been a huge benefit to our clinical staff. We do have cameras that are installed in every patient room in our med-surg intermediate units in our health system. And so that's the equipment that we use to go into the patient's room and to have these conversations with them. Realistically, I have seen technology solutions ranging everything from store purchase webcams to very expensive systems. I think a lot of what organizations are doing is looking at current solutions that they have, what they can expand upon, and if there's any current inventory that they have with equipment that they can utilize to complete some of these workflows. And looking at some of the other services we have, we've brought on medication history technicians or pharmacy technicians that have completed the medication intake process, and they do this through the same technology that the nurses are doing admissions and discharges. It takes about 30 minutes for them to do a prior to admission medication list. If the inpatient physician or admitting physician has already ordered medications from that list, by the time our med history technicians get to them, they'll reach out to the physician and let them know of any changes or discrepancies that they've identified in their interview with the patient. And it may also be that they interview the patient, find a discrepancy, and then they'll even talk to a patient's pharmacy, reach out to them, make sure that what the patient has stated is correct, and then go back to the physician to make sure that the medication that we're administering to the patient while they're in the hospital is the correct medication, and that we're not deterring from their home regimen if we don't need to. The goal for this program is that we would get to the point where we would be able to deploy our medication history technicians in our emergency departments on admission. Current state, we have a couple of trials where we're able to do that through some bots that we're utilizing through our health system, but also in our units that have our virtual technology. We have been using that as well. We just would really like to be able to have our medication history technicians complete their workflow prior to the admitting physician getting to them and ordering those medications, so that they don't order medications that then we find out are a little bit different from what was originally on the list. and we have to ask them to rework that. This has been a huge satisfier. Also, the ability to complete med history technician interviews virtually has actually allowed us to launch this program. Prior to having our virtual solution, we looked at this program multiple times. One of our entities actually launched the program, but generally speaking, and this is really something that we mirror along the nursing side as well. But if you have a staff member who's in one place for 8 hours a day, how do admissions work during that time? How many patients are they realistically going to see? And can you maintain efficiency in having that person there for those hours and the work coming in steadily? With having a virtual solution, we have the ability, not only for our med history techs, but for our nurses, to cover multiple campuses at the same time. We have 4 large metro facilities and 4 critical access hospitals that our teams are servicing, and we're able to complete, a admission at one location, and then do a patient who is sitting at another location and bounce back and forth as necessary to be able to not only have efficiency, but to be able to service all of those areas, which also helps with making sure that you have an efficient FTE count. Additionally, we have social work. Our social workers are doing very similar to our nurses as far as the virtual team is taking on a lot of those more clerical related social work tasks that can be done in an offsite location. You don't physically have to be in the hospital to do that. So the use cases for that: insurance authorization forms, facility placement calls, current PTOT notes for pending authorizations. And again, this entry point here for the equipment is that equipment that is installed in our inpatient rooms. So for virtual expert care, we currently have 3 different kind of buckets as far as what we're utilizing the software for. That is including pharmacy, nursing, and social work. You can go to the next slide. So what's the value for the system? I kind of touched on this a little bit in the last slide, but I think to go through it a little bit more in depth, we have this technology in all of our what we call med-surg intermediate units, with the exception of we have 4 high acuity units that have cardiac transplant where we haven't implemented this technology. But what it has really done across our health system is level set all of those MSI intermediate units where the workflows are the same, the team-based approach of having a bedside nurse and a virtual nurse is the same. When we only had 1 unit in our health system, that was really challenging for our float pool staff, for that team, when you were floated to that unit, to have a workflow that was so specialized and to really efficiently use the virtual nurses and our virtual team if you weren't regularly exposed to those workflows. In addition to that, we could standardize our workload validation. So as we were looking at what cares are done on each unit and how are those cares being completed, we were able to, again, just really standardize that because we had the same team, the same makeup, and the same patient ratios for all of those areas. So it allowed for us to kind of have a level playing field across our organization. In addition, this was just one portion for our system of work streams that we were optimizing during this time. We had 11 different work streams that we were using to make sure that our appropriate caregivers were given the appropriate tasks. Frequently, I think with nursing, we tend to take on all of the tasks, and there are times where there are different items that could be delegated. And so we wanted to know how to inherently build that delegation into the workflow and not require a single person or individual to delegate those things, and to make it just inherent in our workflow. So during this time, from a system value perspective, we were able to increase about 50 staff beds with the implementation of this model and standardizing the team that was taking care of the patients. We had about a 30% decrease in licensed RN demand with the addition of nursing assistant staff and our virtual expert care team. And then we were able, with the implementation, our full-scale implementation of 550 beds, to immediately reduce our agency and temporary help spend, which was obviously an important goal as we were trying to make sure that our health system dollars were being spent within our own labor force and not on temporary help. Next slide, please. So some takeaways from what we're doing here at our organization. I think that there's probably a lot of folks who are on this call that are already evaluating some type of solution like this for your organization. Maybe you are in pilot phases, or maybe you're like the St. Luke's Health System, where we were getting ready to ramp up for going from 33 beds to over 500. And so just some important buckets for you to think about, to look at for your organizations. One is, what is your technology investment? You really have to look up, what are the startup costs? What contracts do you already have in place? How are you going to structure the cost of a program like this? You can see it done by hours based on different units. You can see it done per bed for your health system or for your hospital. And then additionally, making sure that you have the correct service contracts in place. That was something that came up specifically within our St. Luke's Health System because of how we decided to categorize and put the cost center for these virtual nurses. And then in addition to that, we span multi-state. So we are in Kansas and Missouri, and we really had to look at the regulations. And this actually has bled into all of our different disciplines. What are the state regulations for a pharmacy technician? What are the state regulations for an RN? And how do you make sure that your program is meeting those while you have caregivers who are taking care of patients in multiple states in the same day? Really evaluating for your health system, what work streams can you optimize in addition probably to virtual nursing? I think that the majority of organizations current state are really trying to evaluate, what is the nursing documentation burden? Is there documentation that can be taken off of the nurse's plate? What documentation has to be completed? How are you completing your shift handoffs? How do you and your patients order meals? Is that something that a virtual nurse could help with? Is that something that maybe a virtual nutrition tech could help with? I think all of those are questions that we should be asking ourselves as we're looking at future state staffing. Also looking at, what type of scale would you like to be in the long term related to a program like this? When we very first started our program in 33 beds, we were just trying to figure out what it looked like for our organization. And then there were a lot of different items that we had to go back and rethink when we were talking about a 500 plus bed organization, and how there was no way our virtual nurses were going to be able to be texted for every admission that came into the unit. We have days where there's over 200 patients who are admitted, and there was no way that we were going to be able to just utilize text message. We had to really automate those workflows so that it was embedded in the day-to-day of not only the bedside team, but the virtual team. In addition, looking at your recruitment and retention of staff, I think this is always going to be a common thread when you're talking about a solution that is going to hit staffing. One is that there are some experienced staff in your organization that probably have said things along the lines of, I don't know how much longer I can do this physical task. I don't know how much longer I can take the physical burden. And this is an option for nurses who absolutely love and want to stay in the acute care setting to be able to do so, to be able to take care of patients who are physically in the hospital without some of those physical demands. Another huge win for our organization as far as staffing has gone is we have nurses who are on light duty, who have maybe had surgery, someone who needs to be out for surgery, and they're not able to return to their unit for an extended period of time because of the restrictions related to some of those procedures or life events that they've had. And this gives them a chance to do work that they are already competent to do, and to not have to deplete maybe their benefits, their PTO, or anything along those lines. That's been a large satisfier for a lot of our nursing staff, to have that ability to do something different besides take their time. Additionally, from a mixed model perspective, we have had nurses that have come into the virtual center, and the majority of them still every 2 weeks work at least one shift at the bedside, so that they still get that bedside patient care, keeping up on their skills, which a lot of them are very, that's something that's very important to them. That's something from their life perspective. They don't want to lose all those skills that they've worked so hard for. And this gives them the opportunity to work virtually, to not have as much of that physical demand, but also to be able to help patients and not only be virtual, but be in person. Additionally, as far as recruitment and retention goes, our virtual unit has over 90% retention rates. We have excellent retention. Our average length of service for a virtual nurse, their years of experience right now is averaging about 12 years, which is pretty amazing. I wish that my bedside units had an average year of service of 12 years. That would be excellent for us. And also, I think as far as helping out the bedside staff and making sure this is really a team approach, we do a lot of shadowing with bedside staff at the virtual center so they can see what the virtual nurses are working on. We can help sign off on competencies for admission, discharge, and that is extremely helpful for our new nurses to come in because a lot of times on their first shifts, they are not able to see 5 admissions, really learn the workflow, do the workflow, teach the workflow. And so this is an opportunity for them to really have that, that repetition in one shift. And the same thing for discharge. So those are really, that's really beneficial for us. Right now, as far as admissions go, we're completing over 1,200 admissions a month, which is saving the bedside over almost 1,000 hours of bedside work that is absorbed into our virtual nursing center, so that our bedside nurses can take some of the tasks that they have to do that require that physical touch, and our virtual nurses can take on the other portions of that. So with those statistics, I think we can kind of open up for questions.
Thank you so much, Kelsey. We've got some great questions coming in the chat. We're going to get to them at the conclusion of all the presentations, but I have a quick question for you. You know, you had mentioned the imbalance of supply and demand of the healthcare workforce, and just wondering, how has virtual expert care created more of a balance in the healthcare workforce?
Absolutely. We have nurses who, you know, will talk about how if it wasn't for their virtual nursing job, they would have left the workforce at this point. So it's incredible to see, to be able to retain not only their knowledge, their spirit, but to have them there. And then also we had a lot of beds that through the pandemic and after, we had to close because we didn't have the staff. So to implement a care team model where we had a bedside nurse and a virtual nurse working together allowed us to reopen up some of those beds, which is going to address some of that and imbalance in demand and supply that we talked about in that first slide.
Wonderful. Thanks again so much for such a great presentation.
Yeah.
This time we'll hand it over to Carol.
Thank you. ReadySimGo delivers patient and family caregiver education powered by simulation. We are a nonprofit organization dedicated to teaching caregivers of children with medical complexity the knowledge, skills, and confidence they need to safely care for their child at home through simulation. We are an early startup that was founded actually based upon my DNP work. And it was a study that showed that using simulation improved parents' abilities to take care of their children at home once they left the hospital. We are very fortunate to have the support of Johns Hopkins Technology Ventures and have advanced our work through Boston Children's Hospital Innovation and Digital Health Accelerator. We're also grateful to the ANA Innovation Team for all their support over the last couple of years. In 2021, our first year, we were invited to participate in the National Science Foundation I-Corps training. We were also awarded second place in the Healthcare Information and Management Systems Society Nurse Pitch Competition, sponsored by the ANA and BD. We're really excited to tell you about our work and especially our efforts to improve care virtually for children and their caregivers. Next slide. The mother of a medically complex child wrote, "I felt like a nurse. I didn't even know him as a mother anymore." So I'd like you to imagine being the parent of one of the 15 million children with medical complexity. As a new nurse, I took care of a family whose little girl had just been diagnosed with leukemia. Just as her parents were still processing her diagnosis, They were learning to perform a sterile dressing change and other complicated procedures. I walked into the room just before discharge, and the mom collapsed in my arms. Trembling, she asked, "What if I do something wrong at home? What if I hurt my baby?" I never forgot this family, and they were the inspiration for Ready, Sim, Go. Next slide, please. For parents of children with complex medical needs, I do and I understand is the be-all and end-all of patient and family caregiver simulation, hands-on, interactive, repetitive practice in a safe learning environment. Next slide, please. And next, thank you. Medical care for these children equates over $5 billion in healthcare costs. Next. Care has moved from the hospital to home, and these caregivers provide much of the same care like nurses. Next. The shortage of nurses and completing clinical tasks means nurses have limited time to teach. Parent education is often delayed until just before discharge. And family caregivers often become like nurses. Readmissions, often preventable, account for $1 billion in added costs. Next slide, please. Next slide. By transforming discharge education through hands-on and virtual simulation, Ready, Sim, Go can improve caregiver knowledge, skills, and confidence. We know this from thousands of studies demonstrating that simulation is the most effective way to teach new skills. Our Ready, Sim, Go team members have published multiple studies demonstrating the success of teaching caregivers with simulation. Next. It started before, but especially following the pandemic, there has been what some call a renaissance for virtual learning. Next slide, please. Our business model looks at the needs of both hospitals and home care agencies, as well as patients and family caregivers. We teach children's hospitals how to build a patient-family caregiver simulation program in their institution. And we help caregivers learn how to care for medically complex children using hands-on interactive simulation. Next slide, please. Our value proposition is built upon, can you go back? Thank you. Our value proposition is built upon what hospitals place high value on, and that is that Ready, Sim, Go contributes to raising scores by improving discharge education and patient satisfaction for each of these avenues for recognition. So hospitals are, as you all know, very, very dependent upon patient satisfaction and abilities to attract top talent. And particularly, especially in children's hospitals, we see a high value placed on US News and World Report, as also HCAHPS scores. And Ready, Sim, Go contributes to raising those scores by improving discharge education and patient satisfaction for each of these avenues for recognition. Next slide, please. Now let's look at some virtual simulation, virtual solutions Ready, Sim, Go offers to clinicians and caregivers. We are excited to be presenting our first virtual workshop in January 2024. This is a virtual series that will teach nurses, physicians, and simulationists how to build a patient and family-centered simulation program in their own institution. Attendees will learn from nationally recognized experts in the field and will participate in large and small group activities, learn from podcasts, videos, and other offerings. By the end of the series, participants will have a blueprint for building a patient and family-centered program in their hospital. Next slide, please. When there are multiple caregivers, live streaming discharge education is another advantage of virtual technology. It can take the discharge education training session to spouses at work, grandparents, and other family caregivers in their homes. In addition, school nurses, daycare center workers, and others can learn how to safely care for this child through online learning. Next slide, please. On-demand virtual simulation is also another way that we are leveraging this new technology. We are exploring collaboration with several virtual simulation creators, including Open Pediatrics, which is an open access global online community funded by Boston Children's Hospital and other funders. Virtual simulation is currently in development for patients and caregivers and includes scenarios on ventilators as well as hemo and peritoneal dialysis. They are interested in partnering with ReadySim Go to develop scenarios for G-tube, central lines, asthma, and diabetes care. We've also met with multiple commercial simulation companies as potential partners for developing virtual content. These simulations can reinforce what caregivers were taught in the hospital, because often going home can be overwhelming, and having these virtual scenarios available on demand online could be life-saving. We are also developing mobile apps where this type of virtual simulation will be accessible. Next slide, please. Once families are at home, this is an opportunity for caregivers to review their strengths and challenges with a nurse educator. Each workshop will focus on one type of technology, such as tracheostomy care or conditions like diabetes. Next slide, please. Before I wrap up, I wanted to acknowledge our extraordinary ReadySim Go team members. I am privileged to have such dedicated, knowledgeable, and enthusiastic members of my team. Dr. Jennifer Arnold is a nationally recognized simulation expert, as well as a neonatologist. And she is the director of simulation at Boston Children's Hospital. Michelle Whalen is a nurse practitioner in the NICU at the University of Michigan. She is also the director of simulation at the University of Detroit Mercy. And Jennifer Coldren is the manager of quality improvement at Children's Hospital of Philadelphia, and she is an expert in patient and family-centered care. Next slide. So thank you so much for having me today. And if you have any questions that are not answered during our Q&A, I will be more than happy to talk with you by phone, email. Don't hesitate to contact us. We would love to tell you more about ReadySim Go.
Thank you so much, Carol, for such an excellent presentation. Before I get to the questions in the chat, I had a quick question for you. How did you form your team of experts? I really appreciate that last slide and just wondering how you found your team.
Well, it was sort of a series of different building on different relationships. Dr. Arnold is very well known in the simulation world, and I was actually introduced to her while I was at the Children's Hospital Association, and she was doing some work with hospitals trying to teach them about patient-centered care. Interestingly enough, some of you may recognize her name. She is also been featured in a television show called The Little Couple, and she and her husband have shared their story of their journey of being little people and their children, raising their children. And so she's very well known, and we have been partnering together since 2018, and I couldn't ask for a better partner. Michelle Whalen, the way that I met her was that I mentioned the I-Corps training, and part of what you do in I-Corps training is you do a series of customer discovery interviews. And I went to the literature and found that Michelle had published a study on using simulation to teach parents of children with tracheostomies how to care for their child before they left home using simulation. And in the course of the interview, Michelle shared with me that not only was she a nurse practitioner and a nurse educator and a simulation expert, she had raised a daughter who has been ventilator dependent since birth. And so she sees this both from the perspective of a nurse and a simulationist, and also as a parent. And so I just thought that, maybe she might be interested in working with our team. And sure enough, she's been a wonderful contributor to our work. And then lastly, Jennifer Coldren is an expert in patient and family-centered care. She has done work with Children's National Hospital, and she is also on the board of the Barrel Institute, which is dedicated to patient and family-centered care. And so I had worked with her at the Children's Hospital Association and knew of her tremendous skill set and thought it would just be the other perspective that we were missing. And so I am self-funding this company right now. So I am very, very grateful to each and every one of them, because I do not pay them the big bucks yet. But they show up every week for meetings, and they've been a wonderful asset to our work.
Thank you so much for sharing that. It's very helpful because we know that innovation comes from the collective. So having some context around how you formed your team and the why behind that is wonderful. So thank you so much. I'm gonna go into the chat and start with some questions because we've got some absolute wonderful questions and I appreciate it. Please keep them coming. They're very helpful. Let's see here. Thank you for your patience. 1 moment. This is going to be for Tammy. Does Teladoc offer any home-based cardiac rehab?
That is a good question. So to my knowledge, we don't offer home-based cardiac rehab. That is a new question that I haven't heard before. So what I will do, either myself or Barb, who's on my team and answering a lot of these questions as well, we'll get the contact information of the person who asked that question, and we'll circle back around with you if we have a different answer.
Wonderful. Thanks so much.
Of course.
And this question could be for all three. What does virtual nursing look like in the day-to-day? Anyone wants to start with that?
Yeah, our virtual nurses here at St. Luke's, we have kind of a tiered staffing model throughout the day because the majority of the work that we are completing has to do with admissions and discharges. And when you look at your pattern of admissions and discharges throughout your health system, it probably has some type of a bell curve to it, with that afternoon being the busiest time. So we are staffed 24/7 with our virtual nursing team. Our med history technicians are not 24/7 right now. They're Monday through Friday. They start early in the morning, 7:30, and finish about 9 o'clock. But our virtual nurses are 24/7. We start with 2 to 3 nurses in the morning, depending on the day of the week. And then we get up to 13 nurses by the height of the day. And then we're going to go back down to having 2 nurses in our overnight hours after about midnight, when the majority of our mid-shift staff has left. So day to day, our staffing is going to flex as the work is going to flex. And then in addition to that, our virtual nurses are located at an off-site location, not within our hospitals. They're in our technology campus. And so those virtual nurses work out of a patient list that's going to queue based on either admission to a specific unit, or when discharge orders are in and the bedside nurse has queued that the patient is ready for the patient to start the education process. So day to day, our virtual nurses, we really utilize our EMR to queue the work that needs to be completed, so that there's not a lot of back and forth communication, either via phone calls or text message or secure chat. We want to make sure that our EMR is really the source of truth, and that all can kind of be seen retrospectively if we were reviewing charts. But the staff have the ability to talk throughout the day if they needed to. As far as bedside and virtual, we can be found through our secure texting platform if they do need to reach out outside of the EMR. And then our virtual nurse staffing is going to have that, day to day as far as our bell curve and being most staffed in the middle of the day. Additionally, we have our roles and responsibilities organization chart that went live with our go live, and then is also part of our unit-based competencies that our unit staff kind of understand the role of the virtual nurse. They have to review that on hire, make sure that they understand what the tasks are that belong to virtual nursing and what tasks belong to bedside staff. So that there's just clear delineation of roles. We found that to be so important, not only with our implementation, but in that continued use of our virtual team, that everyone is very aware of what is my responsibility, what is the virtual nurse's responsibility, and what are some of the things that we can share if we need to.
Thank you so much, Kelsey. And then another question that we'll start with Kelsey, because it was directed for I'm sorry about that. Can you hear me?
Yeah.
Okay, perfect. It was a question directed for any challenges that you've faced, but we'll also have Tammy and Carol talk through maybe barriers, because I feel that's a great opportunity to learn from maybe some barriers that have been experienced. So Kelsey, we'll start with you. Any challenges you've experienced?
Sure. With any change management project, I think there's going to be challenges. One of the challenges, just from an implementation standpoint, was looking at the software that we were implementing and how that was going to work with the software that we already had in place. We had a lot of televisions in our health system that had to be upgraded so that we could have the correct technology, because our nurses through our camera system come through the patient's main TV. And so we had to make sure that, just from a barrier standpoint, everything was going to work together and that it was going to work appropriately when we needed to use it. I also think barriers, when you think about implementation of a new process, you're going to have staff that are really excited about the change. They want to use this new technology. They want to be all about using the virtual nurses. And then you're also going to have staff who maybe patient education is part of the reason that they love being a nurse. And we have to work through, okay, how do we offload? How do we make sure that you can take care of your patients? How do we utilize the virtual nurse for you? How do we maintain your job satisfaction? Some of those nurses actually have come over to the virtual nursing center because they love the patient education piece, and we get to do so much of that. So challenges from the equipment side, definitely challenges from the adoption side. But one thing that was so important for us was just making sure that our bedside nurses were involved from the very beginning. They actually are the ones who said, hey, I think that we need to look at what we're doing on this pilot unit and see how that could work in the rest of the hospital. So having those bedside nurses not only really have the idea, but then get to formulate and build what that looks like has really helped with adoption and decreasing some of those barriers that we see when nurses feel like they're told this is something that has to be done and isn't something that it says, hey, nurses think this is a good idea, let's give it a try. And so I think just having everyone really involved and then also being willing to change and being willing to pivot on some of the workflows that we put in place. We knew that when we were first rolling this out across the health system that things were going to need to change and that we were going to have to kind of go back to the drawing board on some of the workflows as we got to maybe a specialty unit that we hadn't seen that population yet. And so just being open to feedback, I think, is so important from your implementation team. And I think really listening to what the staff are saying and trying to find common ground sometimes in between what can the software do to actually be a workflow that the staff are going to not hate and are going to want to adopt. And also, you know, what makes your job easier? If we put more barriers in place, then it's not going to be adopted. So it had to be something that really was workable for not only our bedside nurses, but our virtual nurses. So those are just some of the ways that we overcame some of the barriers that our health system definitely faced throughout not only the build of this project, but our implementation and maintenance.
Thank you so much, Kelsey. Tammy?
I'd love to go next. And I am going to drop into the chat window and I'm going to expand on what I was typing right now. So many of the things that Kelsey just said resonate so strongly with me, and I'll reiterate a couple of them. Number one, so we've been doing these types of programs and implementing, we're coming up against our 40th state where we are implementing this type of program with partners across the US. And these are the themes. Change management, you said it, Kelsey, change leadership. You need it from day one. You need to think through it. You need to recognize that this isn't just putting in a piece of technology. This is about the appropriate insertion of technology and redesigned workflows and supporting people throughout this massive transformation for you to get to those really great outcomes that I was so excited to get to describe. You also need, and I'm trying to help everybody to go faster than slow down. Make sure that the conversations that are happening in your organization are all the way across your executive team. Because if you don't have full executive support, such as from the CEO or the CFO or the CMO, you will struggle to get full adoption and transformation at scale. And so that's just part of the thing that we always coach and remind our partners or our prospective partners about. Starting small. Most organizations start with 1, 2, or 3 nursing units. Understand it, 1 or 2 or 3 use cases like nursing and hospitalist or nursing and chaplains as examples. Capture feedback, fine-tune your program, and then you can scale. It's a really great way to understand the level of transformation that's happening that you want to have happen. And then you get into the wash, the rinse, the repeat, and you go very quickly after that. Delineate tasks. And what I mean by that, you heard Kelsey mention it, and I also put it in the chat. This is about rethinking and redesigning roles and tasks. And so often it's about saying that's not a nursing responsibility, as was mentioned. Maybe that's pharmacy or somebody else, physical therapy. And also that the dividing of roles in your organization based on your pain points and getting really clear, at least as a starting point, who does what, when, and where, and how together is incredibly important to decrease confusion, because you want to have early success to get to sustained success. And lastly, I didn't put it in the chat, but accommodate your patient populations. So if you think of challenges or barriers, as you go from a nursing unit to multiple nursing units, or a single use case nursing admissions to 20 or 30 disciplines using a solution, you're going to have different patient populations on oncology or neurology or the ER or critical care. And you need to be thinking about how your approach needs to be slightly different depending on the patient needs, the patient population, the patient preferences. So once again, this is about transformation and reinventing yourselves. And these are the things that we've learned from a lot of implementations that are helping others. We're paying it forward based on work like with Kelsey and others. This is what they've learned. Apply it to your program as you move forward.
Wonderful. Carol?
So you can imagine the response that we get initially when we suggest that we change discharge education and integrate simulation and ask nurses to be a part of this process. Doesn't go over very well. So that's our biggest challenge initially. But once we are able to get people to understand that what we're trying to develop is a partnership between the nursing discharge education role and the simulation center's ability to help facilitate all of this. So the way that for example, Boston Children's operates, the families are just taken down to the simulation center, and the simulation staff has educators there. And so they help improve the discharge education process because these parents are getting this hands-on, individualized, repetitive learning in a very safe learning environment. And then they go back to their unit, and discharge education goes so much more smoothly. Families feel confident about going home. And it's also, very reassuring to nursing staff and other clinicians to know that there are these other opportunities through virtual simulation once they're home to reinforce what they've learned. And so we prevail ultimately, and it's a challenge.
Thank you, Carol. Thank you. We are going to kind of move a little bit rapid fire style because we have so many great questions and we want to try and get to as many as we can. Couple questions from Karen. So what does the orientation of new staff look like, introducing them to the work alongside the virtual team, and kind of those next steps of the program? And then our bedside nurses who do not want to use the virtual nurse supported. So kind of a bundled question.
I'm assuming Kelsey might want to take that one. I can always add on from a supporter and enabler what I'm seeing elsewhere, but Kelsey, you have like the most practical direct experience with your responsibilities at St. Luke's.
Yeah, absolutely. And I missed the first part of the question, so I'll address the second part first, related to, can the bedside nurses not use the virtual nurses if they need to? Realistically, our goal is that we're actually capturing about 85% of the work related to admissions and discharges. So with that goal, we know that there are going to be certain individuals who need to complete their admission or their discharge themselves. And we wanted to make sure that we leave that buffer in there, because there are times where it's actually more appropriate for the bedside staff to complete the discharge. We would never want to decrease our hospital throughput, delay discharges. If there is a bedside staff member who has capability and capacity to take care of that patient and to do so timely. So there is that piece in there where we allow for, the bedside nurses to kind of do those things. There's also times where, maybe a family member works night shift and they show up in the middle of the night. And if we are working on another project as far as admissions go, if we're caring for patients, if we're doing something like that, if we're in their procedure with a graduate RN, then we want that family member who showed up at 3 o'clock in the morning and has a med list to go through that information and not wait or delay that care. So there's definitely still the ability for the bedside staff to be able to take on these tasks. I think one of the differences is, are you taking on the task because it's clinically the most appropriate thing to do, or are you taking on the task because there's a trust issue that we need to make sure that we could rectify if there is a trust issue? Because like I kind of stated earlier, as far as the years of experience in our nursing center, we have a lot of years of experience in the virtual nursing center. And we also kind of take into account the fact that these are registered nurses. We have registered nurses who are who are part of our care team. And I think that making sure to know that virtual nurse, when they get on camera with a patient, they can assess whether or not that patient is one who's going to do well talking to someone virtually or not talking to them virtually. And then having the conversation with the bedside staff member at that time. Hey, I've attempted to talk to this patient. Maybe I've reached out to family, can't get a hold of someone. Let's work together to get this completed. Generally speaking, we do want our virtual nurses to be used. And so that's why we wanted to embed that the virtual nurse is the first process, and not utilizing the virtual nurse would be your secondary option. I've seen organizations across the country honestly do this very differently. And I think we have to make sure that if we have resources in place, because as nurses, sometimes we're not always good about utilizing the help that's offered to us, that we try to make sure that we put that in place from really the very get-go. So there is always the opportunity for the bedside nurses to choose that, they want to do their own admission, discharge, something along that line. There's not going to be, there's not going to be disciplinary action or something like that if you don't utilize the virtual nurse. But at the same time, we know that being a bedside nurse is really hard, and there's a lot on the plates of bedside nurses. So this is a solution to help kind of counteract all of those different variables the bedside nurse has going on, and to say, this is a staff member who is dedicated to doing these things. And we want to make sure that they are utilized, because we also need them to be efficient. We don't want to have virtual staff who are sitting there waiting for work to come in. They need to be busy all the time, just like our bedside nurses are, because that's kind of the right thing to do as far as our staff goes. So I hope I addressed that portion of the question. If somebody wants to restate the beginning, I can definitely address it.
No, I think that was successfully captured. So thank you so much.
Perfect.
Thank you. And then would anyone be able to comment on successfully utilizing virtual settings with the pediatric population? And if so, what patient types are you using it for?
Carol, I'm sorry, Olivia, before we go to that, would you mind if I built a little bit on?
Oh yeah, absolutely. Please, Tammy.
I loved the response, and I'd like to underscore a couple of things. One, to get to the efficiencies and the effectiveness and standardization and scalability into the investment that organizations have made, there are those default work streams, but that doesn't ever mean that it has to always be the virtual nurse or it has to be the bedside nurse. This is about communication. It's about collaboration. It's about trust. And it's about meeting the patient needs or the family needs in that moment. And sometimes that may be that, usually this is a virtual nursing responsibility, but in this example, there's this bond that has happened with the bedside nurse, or vice versa, asking the virtual nurse to take on something that may be slightly out of scope of what was initially envisioned, because there's been a very strong bond formed between the virtual nurse and the patient and the family. We see this all of the time, and it's about trust, and it's about the team working together to take care of the patient needs and the care team needs at the time. I'll also underscore that it is about giving quality time back to the bedside team to spend in hands-on care and quality things with the patient that can't be done virtually. And guys, I'm going to be the first to admit, I get the question every single day as a nurse. Well, I want to still provide hands-on care. great. Yes. And this is a way to enable you to actually do even more of that. And so I always encourage people, give it a try, because what we're seeing is if you can give it a try, you're going to probably really like it based on all of the amazing positive satisfaction scores that we're seeing across all of the health systems who are on this journey. Thank you for letting me add those additional comments.
Absolutely. Thanks. Thank you for expanding on that. Anyone care to address like the pediatric populations? Anyone have some experience with that?
It is, I'll start and then look to my colleagues. People are absolutely using virtual in the pediatric populations, but just like I said, your workflow and how you look at solving for an issue on an oncology floor will likely be different than a cardiology floor, than a neurology floor, than an ER. Your patient population is absolutely essential in understanding that and making sure that your workflows and things like how will they be looking at technology as part of their care delivery system is real. But telehealth in the pediatric world is happening across all specialties, as well as it is really taking on in the virtual nursing world as well. So I would encourage you to do just a quick lit review, but also feel free probably to reach out to any of us on this call tonight, and we can maybe connect you with some additional resources as needed.
Wonderful. Thank you so much. I'm going to move to the next question. What virtual nurse workflows did you initially go live with before expanding?
Our first pilot for virtual nursing within the St. Luke's Health System was a little bit more of what we would consider to be an embedded care team model versus kind of a task-based care team model. So in that very first unit, we had 2 virtual nurses that were on 24/7, and then we had a mid-shift virtual nurse who was on because this was an observation unit, and we discharged anywhere from 33 to 45% of the unit every single day. And so we had those additional mid-shift hours to help make sure that we were up to date with our admissions and discharges. So with that first model where we had 2 nurses constantly on the unit from a virtual perspective, right, on the unit virtually, they were actually a little bit more embedded in that they read every patient on the unit's chart. They went through and addressed some of the different workflows. We, on that specific medical observation unit, admit a lot of patients for TICASIN loading, and they actually owned the entire TICASIN process, reaching out to respiratory therapy if they weren't seeing an EKG on the chart, making a reminder that that was there, completing our flow sheet documentation for TICASIN. So there were a few more workflows that they absolutely owned. They were also embedded more in the day-to-day workflow of that unit, and that they were on the group chat for the unit. They were really involved. If someone would say, hey, I need a heparin check, they were already in that group thread. No one had to specifically reach out to them. And they would say, hey, you know, I've got that all remote into your room. I think one of the other large benefits that we saw of having the unit-based virtual nurses was the virtual nurses got to know the staff. And another really important piece in getting to know the staff was they got to know the new staff and the staff who were on orientation. And for about 2 weeks post-orientation, our virtual nurses were paired with our new nurses, where every patient that the new nurse had, the same virtual nurse was assigned to. And we saw a lot of wins in not only the new grad nurses reaching out for questions, but the virtual nurses just really giving a lot of positive reinforcement. When they would look through the patient's chart, they would see that the new grad did a great job of you know, maybe documenting a rapid response that happened, or their education for that stroke patient was just on point for all of the different pieces that we had to have documented. And so those were some real benefits that we had when our virtual nurses were infused into the unit. In addition to that, when a lot of not only our new nurses, but experienced nurses who were maybe completing a procedure that they hadn't completed in a while, those virtual nurses would come on screen. A lot of times they were there to ease the mind of the patient so that the nurse could really focus on whatever the task was at hand. Maybe it's starting an IV, maybe it's putting an NG tube in. I mean, it could be a whole myriad of different procedures that we were completing. And then if there was something during that procedure that wasn't going perfectly, sometimes the virtual nurse could say, hey, they're having some trouble with this. Here's what they're working on. Here's what they're troubleshooting. Or sometimes they would give little tips and tricks through watching that procedure to really help that bedside nurse out. And, it might be something like having the patient look down, tilt their head down for that NG tube insertion. Maybe they had gotten their head up a little bit. And it's just some of those things that, especially when there are nerves involved, it's kind of the first thing that someone's doing. It really helps to have that person on screen. And then they would go and they would kind of debrief in a different room, either if we had an empty room that they could go in and be on camera with the nurse. It could be a phone call after the procedure, or we had some bots that they would be able to talk to the nurse through afterwards and just have kind of that debriefing session to say, hey, you did a great job. This is what you did really well. Here's where you can document some of these things. Additionally, our virtual nurses would be on screen for any rapid response or code blue. That was really beneficial to our providers because they would be able to have that patient's chart open. There's not a lot of space for someone to be at the computer and all of the things that need to happen during those rapid responses. So having a virtual nurse who would be able to have the chart open, they were already very aware of what was going on with the patient because they started their shift off looking through those patient notes, but they could help answer questions. Also, that unit had call lights where the patient themselves could directly call the virtual nurse, and the patients absolutely loved that. They loved that they could push a button. Our average response time was 23 seconds. So in less than 30 seconds, they had a nurse on screen with them who could help work through whatever those issues are. And there's so many times as nurses, we get asked questions that we are like, yes, let me help you figure out what time your surgery is going to be today. But that's taking away from that med pass that you're supposed to be doing at that time, getting those assessments charted in your early morning hours. And so to have a nurse who didn't have those things they had to be doing at that time to be able to offload some of those questions was very beneficial. So those are just a few key things that were completed when we have virtual nurses infused directly into the units. And we're really looking at long-term for our organization. How do we find the best of both of the different models that we've put together and really scale to where we get closer to what we had when we had that one pilot unit, but at the same time maintain the efficiencies that we've gained in our scalability with our system model.
Wonderful. Thank you so much, Kelsey. And then I know we're at time, but just two more quick questions. Is this being used successfully across different EHRs? I see you shaking of the head. Yeah.
Perhaps I'll take that. Yes, most telehealth systems and definitely ours are increasingly doing full or light integrations in collaboration with the EHR. Everybody knows the top financial investments organizations have made has been in the EHRs. However, the EHRs typically aren't as skilled. What we're seeing is a deep collaboration with the EHRs. And I know that we're working with Cerner, we're working with Epic, just as the two big ones as examples across the United States for making sure that it's the right workflow and capabilities that are synergistic versus competitive in a patient room.
Wonderful, Tammy. Thank you. And then finally, last question, have virtual patient acuities been validated, and do we have virtual RN staffing ratios?
So when we first went live on the unit, our staffing ratio, we were a kind of an interesting 33 bed unit. So we had two nurses, one was taking 16, one was taking 17 at that time. I'll tell you, this is, when you talk about pioneering something new with healthcare, I think it really depends on the model and how many patients the virtual nurses are taking. I've heard everything from virtual nurses who complete your unit-based rounding. They just do so virtually, being at a 5-to-1 ratio. to hospital systems who utilize their virtual nurses only for admission being at technically 100-to-1 ratio. So there's really not necessarily a standard. Depending on what you're looking at, you're going to want to probably shoot for around 20-to-1, depending on what type of work stream that you have. But it really just depends on what they're doing, how long it takes a typical person in your organization to do that, and how you gain some of those efficiencies. So there's not necessarily a standard there. It really kind of depends on what type of model you're going to adopt to, and also making sure, of course, from a business standpoint, that this is something that is, you know, either helping your organization financially, or it's something that is creating enough of an efficiency that you're able to take on that cost and still be efficient enough to work through that, and making sure that your organization is kind of smartly spending the dollars that are necessary.
Wonderful. Well, thank you so much for such an insightful evening. My goodness. Thank you to Tammy. Thank you to Kelsey and Carol.